My name is Sam Akai, and I am a student physical therapist that's going to perform an evaluation on a neuropathic ulcer. The patient is a 62-year-old male with insulin-dependent diabetes mellitus and multiple other comorbidities. He ambulates household distances and does not work. Lastly, he is inconsistent with glucophage and insulin use and has an uncontrolled diet. The neuropathic ulcer is located on the base of the first metatarsal head of the left foot. It is 2.2 centimeters long, 5.7 centimeters wide, and 3 centimeters deep. There is a 2 centimeter tunnel at the 12 and 6 o'clock positions. Also, it appears to be infected based on the white colored discharge or pus and the red and edematous surrounding tissue. I would classify this wound as a stage 4 neuropathic ulcer because the depth measurement is far past the dermis layer, and there's tunneling and slough, and there is exposed muscle. The outcome measure I perform are the monofilament tests with a 10-gram monofilament to assess sensation. Also to assess sensation, I would perform the Ipswich touch test. I would also perform the up and down test to measure proprioception of that foot. And then I would assess the vascular supply of the foot by checking the temperature of the foot, capillary refill. I would assess the pedal pulses. And then lastly, I would take a 4-foot edema measurement because there does appear to be swelling. The etiology of the wound is directly related to the uncontrolled insulin-dependent diabetes mellitus of the patient. He is inconsistent with his use of glucophage and insulin and is also hyperglycemic. These risk factors have likely caused decreased peripheral circulation to his foot, as well as diabetic neuropathy. He likely stepped on an object that caused a small wound at the base of his first metatarsal head, and his diabetic neuropathy prevented him from feeling this when it happened. This happening and then his impaired peripheral circulation, that combined caused the wound to not heal properly, and then it slowly deteriorated to where it is at presently. Due to these cellular processes, I would likely categorize this as a chronic as opposed to an acute wound. This patient has a few barriers to healing. The first barrier is that the patient is inconsistent with taking his prescribed medications, as mentioned, glucophage and insulin. The second barrier is that the patient lives a somewhat sedentary lifestyle with also a poor diet. These barriers both indirectly lead to decreased healing ability by lowering the perfusion of blood and oxygen to the extremities. By being inconsistent with glucophage and insulin, he's increasing the blood sugar in his body, causing damage to his blood vessels. By living a sedentary lifestyle, he is also not increasing perfusion to his extremities by increasing his heart rate and blood pressure. Also, his poor diet, it doesn't mention specifically, but he does say he likes to choose what is cheap and fast, which I'm assuming is fast food. And this would also contribute to his increased blood sugar and indirectly leading to most likely decreased peripheral circulation. A couple solutions to these barriers. First one being I would educate the patient to remain more consistent with his medications, glucophage and insulin. This could help control his blood sugar without having to alter his lifestyle significantly. Secondly, it may also be beneficial to motivationally interview the patient to encourage a more active lifestyle. This can mitigate a lot of the effects of his poor diet and inconsistent use of his medications. The reading tools I would use, first of all, would be a pulsatile lavage. And if necessary, after that, I would use a curette to remove specific areas of slough and pus. I am aware that there is exposed muscle, so the curette would have to be used very cautiously. I would then rinse the wound and the surrounding area with saline after this debridement process. I would not use the wound cleansers, though, because they are too abrasive for a wound of this depth. The Dakin solution, I believe, is not indicated for this wound, specifically for the aforementioned reason of a wound cleanser would be too abrasive for a wound that deep. However, the betadine soaked dressing is indicated because the wound appears to be infected, and it's also deep enough to need to be packed. So the betadine would be a good solution to combat the infection of the wound. The first dressing I'll use is a betadine soaked dressing to pack the wound with. This will help control the infection and minimally soak up any leftover exudate. I will then cover this packed wound with a semi-permeable foam dressing. This will allow the wound to breathe and not let bacteria in. And it will also help with being somewhat absorptive itself and picking up any exudate that the packing did not. In terms of patient education, I would like the patient to not walk directly on the healing wound when they ambulate. I still want to encourage them, though, to get up and move to promote blood flow, but protecting the healing tissues, kind of keeping that in the back of their mind as they ambulate or move around. I also do not want the patient to submerge their foot in water. This increases the likelihood of infection and will require a dressing change, most likely, which could hinder the healing process. I want the patient to leave the dressing on until they see me again, as long as that's within the next 7 days. Lastly, my 2 goals. First being, in 2 weeks, I would like this wound to not produce any more pus to demonstrate decreased wound infection. The second goal is that in 1 week, the forefoot edema circumference would decrease by 2 centimeters to demonstrate further decreased wound infection. So that concludes my wound assessment. Please contact me if you have any questions. Thank you.